Welcome to Great Plains Quinn Friday Focus for Health. This Friday Focus for Health is hosted by the Great Plains Quality Innovation Network, the Centers for Medicare and Medicaid Services Quality Innovation Network, Quality Improvement Organization for North Dakota and South Dakota. My name is Carrie Sorensen, and I am a pharmacist and quality improvement advisor for Great Plains Quinn. Joining me in this presentation today is my colleague and registered nurse, Jennifer Lochner. She is also a quality improvement advisor for Great Plains Quinn. Our other team members today with us are Stephanie Maduna, Carolyn Tufty, and our communications specialist, Kelsey Olson. We want to thank you for all joining us today. Today's webinar is being recorded and will be posted within 1 to 2 business days on our website at greatplainsquinn.org under the Friday Focus for Health link, which is being shared in the chat. The chat box is also where you can ask any questions during the presentation. We will provide a link to our resource handout that includes all the resources shared during today's session and will be added to as the 4-week series evolves. Before we get started, I would like to play a quick video on healthcare-associated infections.
Sorry, guys. I was gonna just put it down a little bit. Give me a second here. Sorry.
On any given day, about 1 in 25 hospital patients have an infection caused
I'm gonna go back here to the video.
by their medical
Maybe.
care. On any given day, about 1 in 25 hospital patients have an infection caused by their medical care. Almost half of these patients are 65 or older. There are 5 places where patients are most likely to get infections: in the bloodstream, the urinary tract, the gut, and the 2 most common places are the site of surgery and the lungs. The germs most likely to cause healthcare-associated infections include C. difficile, or deadly diarrhea, staph, including the drug-resistant type known as MRSA, a family of germs known as Enterobacteriaceae that includes CRE, the nightmare bacteria, Enterococcus, which can be resistant to an important antibiotic, vancomycin, and Pseudomonas, which can cause infections of the lungs and bloodstream. 1 in every 9 patients who gets an infection will die during their hospitalization. Over the last several years, great progress has been made in preventing some infections. For example, bloodstream infections in patients with central lines have been nearly cut in half in the last 5 years. But more work needs to be done. CDC's goal is to eliminate all healthcare-associated infections. We work 24/7 to save lives and protect people.
So I just wanted to highlight the top infections that we are all really working hard to decrease in our various facilities that we work in. And as the video stated, there's 5 places where patients are most likely to get infections, with the 2 most common places being surgical sites and the lungs. And so today we will focus on the lungs. So in our time today, we are going to talk about pneumonia. I want to mention a few acronyms as we get started, just to help categorize different types of pneumonia, and these have really evolved over time. So ventilator-associated pneumonia, or VAP for short, is of course ventilator or a pneumonia that's attributed to a ventilator being used. And then there's hospital-acquired pneumonia, or HAP, and non-ventilator hospital-acquired pneumonia, or NVAP for short. So HAP and NVAP are used interchangeably in the literature. And then lastly, CAP is community-acquired pneumonia. And you probably have heard us talk about a category in the past called HCAP. and this is healthcare associated pneumonia. And we really have abandoned the use of the term HCAP because it has led to the unnecessary overuse of empiric antibiotic coverage for MRSA and Pseudomonas. So today we will also look at some prevalence data based on different risk factors for pneumonia. What are some prevention strategies that will be applicable to all categories of pneumonia? And then we will focus in on oral care and the connection to pneumonia. And at the end, we will share some best practices that you can put into action as soon as this session is over. Pneumonia is a common nosocomial infection and continues to cause the highest hospital-acquired infectious mortality. The overall incidence of hospital-acquired pneumonia varies from 6 to 8.6 per 1,000 admissions in high-income settings and is substantially higher in resource-limited settings. HAP on average increases the length of hospital stay from 7 to 9 days at an additional cost of more than $40,000 per patient. And it is responsible for 1/4 of all ICU infections and half of all antibiotic use. In addition to socioeconomic status, race can impact pneumonia rates as well. People from non-white ethnic backgrounds are between 1.3 and 23 times more likely to have other health conditions that increase their risk of severe influenza and pneumonia. The Black-white fatality disparity is perhaps the most pronounced, with pneumonia deaths 16% higher in Black people compared to whites. Studies indicate that it is not a physiological difference in these ethnicities that contribute to this disparity, but rather factors like structural racism, social factors like smoking and living in crowded conditions, having a mistrust in the healthcare system, and barriers to access healthcare services. As you can see in the table on the right, age and gender impact prevalence as well. Higher rates of influenza and pneumonia are seen in males and in those with advancing age, with overall mortality rates rising significantly to nearly 400 deaths per 100,000 adults aged 85 and older. These disparities represent another example of the importance of advancing health equity. Beyond specific age groups, ethnicities, and socioeconomic factors, there are also a number of other diseases and conditions that can increase the risk of developing pneumonia. Other examples include neurological or brain conditions such as stroke, head injury, dementia, and Parkinson's disease, swallowing disorders that could lead to inhalation of food, saliva, or other fluids, pregnancy, HIV and AIDS, bone marrow or organ transplantation, and immunosuppressive medications such as chemotherapy, steroids, and other anti-rejection medications. Severe illness that requires hospitalization, perhaps an admission to the ICU setting, and mechanical ventilation. Lung diseases such as asthma, bronchiectasis, cystic fibrosis, COPD, and injury from smoking or vaping exposure. Malnutrition, diabetes and heart failure, kidney and liver disease, and sickle cell diseases. And it is notable that in about 50% of cases of sepsis and septic shock, pneumonia was the underlying cause of infection. Now we will move on to some non-ventilator hospital-acquired pneumonia or NVAP prevention strategies. These were released by the Joint Commission about 18 months ago. Since the development of pneumonia requires a complex interaction of events that includes aspiration of microorganisms present in the oral cavity and a vulnerable host, most prevention measures target primary source control. And these may include maintaining regular oral care, maintaining patient mobility, elevating the head of the patient's bed, reducing the use of acid-suppressing medications. And with these medications, the gastric acid in our stomach is not a conducive environment for bacterial growth, but when the pH increases from these medications, the bacteria can flourish and then be aspirated into the lungs. And this is just one risk of long-term use of these medications, such as proton pump inhibitors. Other prevention efforts include minimizing sedation to decrease the risk of aspiration, performing dysphagia screening in high-risk patients to assess for problems with swallowing. If swallowing is impaired, using modified diets and feeding strategies. Following standardized processes to place and manage feeding tubes. Using respiratory therapy techniques such as breathing exercises, chest percussion, and incentive spirometry. And last but not least, educating our patients and family about NVAP prevention to promote the importance of good oral hygiene and increasing mobility. Of the prevention strategies just mentioned, oral care should be at the forefront. Pneumonia is among the most common infections that occur in healthcare facilities, and NVAP is really a risk for virtually all hospitalized patients. And this is often caused by the bacteria from the mouth that gathers in that scummy biofilm on unbrushed teeth and is aspirated into the lungs, thus triggering an infection. According to the National Organization for Non-Ventilator Hospital-Acquired Pneumonia, or NVAP prevention, which was founded in 2020, this pneumonia infects about 1 in every 100 hospitalized patients, and 15 to 30% of them die. For those who survive, the illness often extends their hospital stay by up to 15 days and makes it much more likely they will be readmitted within a month or transferred to an intensive care unit. Although NVAP accounts for most of the cases that occur in hospitals, historically there's been much more focus on ventilator-associated pneumonia. Pneumonia is a common infection in non-hospital healthcare settings as well, such as nursing homes. Prior to the pandemic, pneumonia was the leading cause of hospitalization and death among residents, accounting for an estimated 40% of hospitalizations and up to 33% of deaths at that time. The two modalities that show the best evidence of preventing this harm are things that should be happening as part of standard care anyway: brushing teeth, elevating the heads in beds, and getting patients out of bed more often. There are a smattering of studies that show these two strategies can lead to sharp reductions in pneumonia rates. In California, a study of 21 Kaiser Permanente hospitals used a reprioritization of oral care and getting patients out of bed to reduce rates of hospital-acquired pneumonia by about 70%. And the most compelling results come from a veterans hospital in Salem, Virginia in 2016, where an oral quick care pilot program reduced rates of NVAP by 92%, saving an estimated 13 lives in just 19 months. This oral care program, called the HAPPEN Initiative, stands for Hospital-Acquired Pneumonia Prevention by Engaging Nurses to provide oral care. And this has been expanded across Veterans Health Administration, and experts say it could serve as a model for all U.S. hospitals. So next, I would like to show a short video used to help train nurses about this program. And even though this is about the VA's program, the information is really useful for all healthcare workers in any facility.
You save lives every day. Did you know that a simple, low-cost way of preventing pneumonia is often missed in the care of our hospitalized veterans? Want to know the secret? Teeth brushing. A clean mouth can prevent diseases like hospital-acquired pneumonia and help our veterans live longer, healthier lives. Hospital-acquired pneumonia is a largely preventable disease that frequently leads to long hospital stays, high healthcare costs, sepsis, and increased risk of death. You may notice that rough or unclean feeling if you don't brush your teeth for a few hours. Billions of germs grow quickly in the plaque that forms on unclean teeth. the germs in the biofilm may be aspirated into the lungs of our patients during sleep, leading to pneumonia. This is why we need to help our veterans keep their teeth clean. Oral care should be provided at least twice a day, after meals and before bedtime. Mouthwash, sponge applicators, and swabs are not a good substitute for toothbrushing, as they do not adequately remove the biofilm from the teeth. If you are concerned about a veteran with swallowing problems and are worried about using toothpaste, you can always remove the germs by gently brushing his teeth with clean water. If the veteran has impaired memory, cover his hand with yours and brush his teeth together. Gentle persuasion and encouragement go a long way in helping veterans with oral care. We invite you to join us in improving the oral care provided to our veterans to prevent hospital-acquired pneumonia. Now that you understand how to prevent pneumonia by helping veterans brush their teeth, please document the excellent care you provide and help us spread the word.
So after watching this video, I personally felt impacted by the fact that while teeth brushing may not seem to require training, sometimes we are searching for the most complicated intervention to make an impact and overlook the simple things we can do in our practice to save people's lives. The VA had also created a shorter 1.5-minute video geared towards the patient and family audience that would be very beneficial to educate our patients. So next, I would like to show you a standardized oral care protocol, a tool that you could adapt to implement standardized oral care for your patients. It outlines oral care for 4 different types of patient scenarios, with the first 2 shown here. It lists the equipment that could be used, the frequency that the care should be performed, and walks through the procedure for each. So you can see in the red there, the first one is self-care and staff assist for a patient that is able to spit with oral care. The aqua section is for patients that are dependent for oral care and are not able to spit and thus are at risk for aspiration. On the next slide is the section in orange that outlines oral care for patients on a ventilator. And lastly, in the green is a section for oral care for patients with no teeth or those with denture appliances. I really love how this tool provides a nice inclusive reference for carrying out proper oral care. So this is just a summary of all the resources that we will be adding to the resource handout, and Kelsey I believe, has dropped that into the chat for us. And in closing to today's information, I just wanted to kind of provide some leave and action comments and just highlight the fact that pneumonia can be caused by a variety of etiologies, and while treatments have improved, it remains a leading cause of death in all age groups. Prevention is the best medicine. Those at high risk of developing pneumonia should attempt to stay away from people who are sick, practice good oral and hand hygiene, and stay up on vaccinations. So as a takeaway, think about a pneumonia prevention strategy that you could consider for your facility. Gather your team and then start a Plan, Do, Study, Act cycle, or PDSA. For example, you could take the standardized oral care protocol and make it available for staff to review. This would be your plan. Then you could implement the protocol, and it is perfectly fine to start with a small pilot before launching this facility-wide. This would be your do. And then next you would have staff perform the designated oral cares for each type of patient or resident and see if your pneumonia rates go down. And if not, reevaluate, make changes, perhaps more staff education is needed, and then repeat this study act step. Other ideas for a PDSA. Explore if patient vaccination status is consistently being reviewed and vaccines offered at every point of care contact. Or look at your processes for ensuring patients are getting out of bed if able. Get your patients and residents moving. If they are not able to get up to move, initiate chest physiotherapy with incentive spirometry or deep breathing exercises. Make sure the head of the bed is at 45 degrees or higher during and after eating or drinking, and for those who are at risk of aspiration or choking. Smoking or nicotine cessation is another QI focus. Are you encouraging patients at every access point to connect with a tobacco treatment program? The Great Plains Quinn website has the PDSA tool along with other tools that you can utilize. And that will be included in our resource handout as well. So now I have concluded what I would like to present today, and I will turn it over to Jennifer Lochner, who will lead us to our time for questions and open discussion.
So if anyone wants to come off of chat and ask any questions that you have, go ahead. This is the time. We can start with a poll that we have. I think that should launch in just a minute here. And the question will be, what pneumonia prevention strategy would you be interested in exploring or pursuing in your facility? Oral care, vaccination, smoking cessation, improving mobility, or any other strategies not mentioned? Oral care and vaccination so far?
While we're waiting for those responses to come in, I just thought that I would say, I really liked that video on the oral care. It was a good refresher on, some tips to do with memory impaired patients. And although it's VA geared, I mean, that applies to everybody. So
Right.
Thank you for sharing that. Thank you for the reminder.
I do like the hand in hand because it makes them feel like they are doing it themselves. Looks like just oral care and vaccination are what everyone wants to work on that has answered so far. We have 5 responses now. And some of those things are so simple, and I love that standard of care with the dental, breaking it down into each type of patient or resident. And it's simple to read. I love the color code. So I think it's great for all your staff. And mobility too. Anyone can get these patients and residents up moving, even if it's just from the bed to the recliner or to a wheelchair. It's changing that position, using those muscles and getting things moving so they're not just laying in bed and everything's settling. Does anyone have a standing order or protocol in their nursing home to avoid an ER visit or hospital admission for pneumonia? You can just come off and mute or answer in the chat. Anything you'd like to share? I just lost my stuff here. How about a oral protocol? Does anyone have one of those in place? things you could have on, say you have a standing order or something in your facility, you can have on their ambulate or get up into a chair so they're not in bed all day. I know we would do this at our facility. We made sure they were up for all meals, out of bed for all meals if it was possible. Good oral hygiene, of course, we reviewed that today after meals and as needed. And then elevate the head of the bed at least 45 degrees for an hour after drinking or eating so they don't have that risk of aspiration. Instead of a spirometry that's simple, have one of those in their room and have them work on that, and that helps expand those lungs, and along with deep breathing exercises too. I've got a slide here on some safety actions if we want to move to that. And I can go through that with you. Okay. So for safety actions to consider, there are actions that hospitals and medical centers can take to prevent pneumonia while improving the quality of care and patient safety, lowering the risk of sepsis, reducing healthcare costs, and saving lives. You can obtain buy-in from your leadership and healthcare providers about the importance of pneumonia prevention, overcome beliefs that prevention strategies such as oral hygiene and mobility are optional tasks rather than standard of care interventions, and implement processes that make oral care mobility an expectation for routine care of non-ventilated patients. Have necessary supplies available to implement effective interventions. Educate staff about the risks of pneumonia and prevention methods, such as aspiration precautions. Provide training on techniques to encourage patients to comply with oral care and maintaining mobility. Evaluate patients for swallowing issues and adjust nutrition and feeding assistance based on this evaluation. You may need to do this more than once over time. People change, their status changes, so you want to make sure you're up to date on those evaluations with swallowing. Next slide. Education or educate patients on risks and prevention methods that are implemented in the healthcare setting and should be continued after discharge. Empower patients and family members to ask for assistance with oral care, feeding, and mobility, and maintaining any needed supplies. Perform outcome and/or process surveillance to determine rates of infection and compliance with processes to prevent pneumonia. Consider using standard definitions such as those published by the CDC to allow for aggregation of data and comparison infection rates with other organizations. Develop operational pneumonia tracking systems to assess the impact of prevention initiatives. Evaluate workflows from a systems perspective and establish processes that facilitate the prevention of pneumonia. For example, ensuring efficient access to supplies and providing job aids when necessary. And implement processes to sustain pneumonia prevention for the long term. And then this is just a slide as a good refresher for the pneumococcal vaccinations and the influenza vaccines. So a good review there. Does anyone have like a simple review card in your facility, or is it set up simple to understand in your EHR?
I know the manufacturers for the pneumococcal vaccines give out kind of like a flow chart. I've even seen like a wheel that you can turn with, if they've had this vaccine, you place it on there and then it tells you what to do next.
So there, you guys can see on this slide too that there's different types of the pneumonia vaccines, which I'm sure you're aware of, and the ages that they should be given. And If they have certain medical conditions, that makes a difference too. And of course, most people should get an influenza vaccine, particularly patients greater than 65 years of age. They should receive the high dose quad, the flu block quad, which is egg-free, or the flawed quad. I don't know if I'm saying that right or not, but the influenza vaccine helps in the prevention of secondary bacterial pneumonia. The flu virus infects the cells lining the mucous membranes in the back of the throat, nose, and bronchial tubes. When they're impaired from the influenza virus, they allow bacteria to trigger a secondary infection in the lungs. So it's always good to get those vaccines if possible.
We had somebody share in the chat here. Pneumorex is a great app for pneumococcal vaccine recommendations too. That's awesome. Thank you for sharing that. Is it Kate or Katie? Kate?
Yeah, thank you. Yeah, Lisa, I love any review we can get on vaccines. It seems like we have a lot of changes with medications and vaccinations and stuff, so it's hard to always keep up.
Thanks for the feedback, Angie and Claire. We appreciate that.
Yeah. Well, if there's no further questions, we want to thank you so much for attending today. Being mindful of your time, we will be ending for today and hope to see you back here next week. Please complete the webinar evaluation so we can continue to work to make our time together valuable. We really appreciate your feedback. Attendees will be dropped off at the evaluation at the conclusion of this call. If it's easier for you, you can scan the QR code with your camera or a smartphone, or click the link within the chat to complete the form. As always, we really value your feedback on these Friday Focus for Health sessions and any ideas on future topics so that you'd like us to cover. Next Friday, we will be talking about UTIs. Thanks again for joining us. We hope you had a great Nurses Week. And for those of you who are mothers, we hope you have a wonderful Mother's Day. Thanks for everything that you do.
Thanks, everyone.
Thank you.